If you're a senior minister or even you're the prime minister, simply saying you want something to happen doesn't mean it happens. Two things that you need to do. One is you need to be really clear what your priority is and you stick to them and you pay attention to them. And then the second aspect is that you try and really understand the system and the complexity of the system within which delivery tends to happen. Healthcare, obviously, there's the health service at the center, then there's lots of different delivery points regionally, locally, all the way down to individual people. And so for someone to change what they do in a particular ward, in a particular hospital, that's a very long way away from the Prime Minister saying, I want this to happen.
Hey everybody, this week I'm joined by Malte Gerhold, and he's Director of Innovation and Improvement at the Health Foundation. Malte started his career as a strategy consultant, went to the British Prime Minister's Delivery Unit, where he was appointed Deputy Director of the Strategy Unit at the Department of Health. Later joined the CQC, but before that lived and worked in Sierra Leone for 3 years, leading a team advising the president on the implementation of the government's priorities in healthcare, energy, agriculture, and investment. Was then executive director of strategy and intelligence at the CQC, and also has a BSc from LSE and a PhD from Oxford. Malte, delighted to have you on the Healthtech Podcast. How are you doing, sir?
Morning, James. Thanks for having me. It's great to be on the podcast.
Let's not talk about how many takes that took me to put that introduction together. So let's just move on swiftly from that. But yeah, honestly, man, like really interesting. What a background. Sierra Leone, advising presidents, British Prime Minister's unit, delivery unit. So much that we can talk about with policy. We've just had a general election, so you'll know some probably behind the scenes stuff about that. The Health Foundation, the stuff you're doing now, AI report just come out and other reports too. So yeah, I am really looking forward to getting into this with you. Before we get going, whereabouts are you speaking to us from? Where are you based?
Good question. I'm actually on holiday in northern Sweden.
Oh, wow.
Where half of my family is from. Yep. So right now it's raining and a bit cold. And I've got about half a meter of grass to mow later on to sort out the
July
garden.
for Northern Europe, eh?
Yeah, no, exactly. That's our own fault.
Very nice, very nice. So Malte, why don't I hand over to you to give us a bit of background? Like, how does one go from, I guess, BScs, PhDs at Oxford, all the way to the Health Foundation via everything that you were doing for presidents and prime ministers? So yeah, why don't you give us the lowdown?
Yeah, thanks for that easy question to start with, James. I don't really know is the honest answer. And I always admire people who can talk about their career path with sort of a straight journey and a clear sense of what they wanted to do. And I studied for quite a long time, partly because I enjoyed it, and I was lucky to get some scholarships to do it. And I actually wanted to become an academic. I mean, I did my PhD is in philosophy, so I was definitely set to become an academic. And then at some point, I think I realized that I don't think I was very good at teaching, and I wouldn't enjoy it very much. And I didn't want to be one of those academics who might be brilliant on some things, but then absolutely awful in front of students.
When you say not very good, what did you realize?
I think I struggled with the answers sometimes. When an 18-year-old asks you a question and you think I should really know the answer, I'm doing a PhD, and you don't really know. And maybe I was overthinking it. I was probably overthinking it at the time. But I think the sort of repetitiveness of some of it, sounds fun if you do seminars and you're writing papers and you have conversations about that. But you also have to be able and willing to really engage year after year in, let's say, introductory philosophy, whatever
it's
it
very
might
true. Yeah,
be.
It's very true.
So I wasn't sure I was very good at it. I've actually changed my mind over the last sort of few years. So I think I would have enjoyed it. But anyway, at the time I thought I was very good at it. And I also didn't just want to sit in a library for the rest of my life and sort of humanities and particularly philosophy is a pretty lonely science. There isn't a lot of collaboration. There's a bit more now because you've got more philosophy that's moving into sort of, collaboration with science and technology, etc. But at the time, it felt very, very lonely. So I basically went completely the opposite way and thought maybe I'll try consulting. They seem to appreciate people with a philosophy degree, and I will have to work with lots of people and learn something completely different. And so I was lucky to get a job there. And the biggest thing for me to learn straight away was that no one reads the footnotes. It's all about the exec summary,
Absolutely.
And the brevity
of
what
headlines these days.
What you say, yeah. So I sort of slid into that career sort of fortuitously rather than by particular design. And then similarly from there to join the Prime Minister's Delivery Unit. It had already existed for a few years, and a job became available that I saw, and it sounded really fascinating and interesting. And I've been working on the public sector side in consulting, but actually not in healthcare.
What's a delivery unit?
So good question. So it was set up.
Sounds like the one office of the Prime Minister that is actually there for doing things rather than just talking about things.
So it was set up a few years into the last Labour government. Don't quiz me on the exact year, but early 2000s, I think. And it was basically coming out of a realization that if you're a senior minister or even you're the Prime Minister, simply saying you want something to happen doesn't mean it happens.
Yeah.
Right. And that what you actually need to do. I mean, this is sort of my interpretation. There are whole books have been written about the delivery unit, but sort of two things you need to do. One is you need to be really clear what your priority is for it. And this has sort of come out in the early 2000s through targets, which obviously been widely debated to what extent targets are a good idea or a bad idea, because they create incentives on people to gain targets, etc. But a clear set of priorities and other targets. And you stick to them and you pay attention to them, including all the way up to the Prime Minister where they're being delivered. And then the second aspect is that you try and really understand the system and the complexity of the system within which delivery tends to happen, which goes all the way from the Prime Minister saying, I've committed to achieve X. And then there's a department, in healthcare, obviously, there's the health service at the center. Then there's lots of different delivery points regionally, locally, all the way down to individual people. And so for someone to change what they do in a particular ward, in a particular hospital, that's a very long way away from the Prime Minister saying, I want this to happen. My first role when I came into the delivery unit was to support the work on reducing hospital-acquired infections, MRSA, C. difficile, for example. So that was literally around individual people's behavior, washing hands, for example, bare below the elbows, all that stuff. And so the delivery unit was set up to some extent to create a link between the sort of political level, particularly Prime Minister number 10, and those complex delivery systems, and to both help translate the sort of political will into those delivery systems, but also in the opposite direction, to identify where in the delivery system actually the political level could make a difference and unlock issues and problems, right? Because you might be hitting a particular boundary, whether it's funding, ways of working, etc. And if you can then get a minister or indeed number 10 to address that particular issue, it can be resolved or it can be unlocked.
Yeah.
But you need someone who, sort of makes that connection between the two. And that's what the delivery unit does.
Interesting. What next in the story?
So from there, I got a good taste of health and healthcare. And I went to the Department of Health, joined the strategy unit there. And sometimes people think of the strategy unit as, a team that's very much about doing the bidding of the minister, doing the job of the minister. When Alan Milburn, for example, was Minister of Health a long time ago, he set up a strategy unit that was very explicitly about helping him to write the NHS plan at the time, sort of work closely with him. That's not what the strategy unit was like when I joined it. It was much more a team that was meant to help facilitate particular pieces of work, whether between the minister and the rest of the Department of Health, or whether between lots of different teams within the Department of Health or across departments, or try and understand a particular problem in order to help identify the solution. So even though it was focused on strategy rather than delivery, it was this very similar job in the sense that it was very much about trying to facilitate compromise and answers and solutions between lots of different teams.
Yeah.
And that's what I did in the delivery unit. I think that's what I did in the strategy unit for that. So I think I got relatively good at that, sort of sense of bringing people together and try and come up with a good answer for it. And so having been Department of Health for a few years in the health sector, so I guess a bit of a moment in my life where I thought, if I do go abroad and work abroad, then this is the moment to do it. Because before I maybe want to settle down, build a nest, build a home. And so I looked at sort of development opportunities and work within them. And I hit upon what at the time was called the Africa Governance Initiative. And it's a charity that's very much focused on supporting sort of political level in developing countries to connect with the wider delivery system, whether that's the civil service or the relevant, health service, agriculture, etc. And so it was very much a skill that I could bring from the work I'd been doing in the delivery unit and the strategy unit to do. So it was a very good fit, and that's what took me to Sierra Leone for just under 3 years, which was very different, as you can imagine. So very different career step, career move. Not really done, sort of in order to advance, so to speak, in my career, but because I just wanted to try something really, really different.
Can you talk about that a little bit? So advising the president on implementing the government's priorities across a few different things, healthcare, energy, agriculture, investment, it's quite broad, that team that obviously you were leading, and a team advising the president. It's really interesting. I heard something that someone said, I think it was on a different podcast, about how the further you go up the chain of people making decisions, the less evidence there is to actually make certain decisions. And people that are advising world leaders, presidents, prime ministers, etc., they have people around them that present one side of the argument, another side of the argument, and then broadly it's a judgment call. And there's very sketchy evidence as to what's likely to be essentially at the other side, because, these types of decisions are often being made for the first time. What's your impression of that? Was that your experience? And how does one lead a team that advises the president on these multiple areas? What does that role actually look like?
So it sounds a little bit like sitting in a small room with very senior politicians and sort of advising them.
Yeah, it sounds very war room.
Yeah, which is not what it's like. It's really two things. One is actually the advice is not really on the particular specific expertise, let's say on energy infrastructure, how to run or improve agriculture, productivity, an education system, sort of a healthcare system, but much more about actually how can you as a minister or senior civil servants, how can you affect that priority and see it through the rest of the civil service and the wider delivery system so that it actually happens. So it's our focus was very much on the advice on how do you do delivery. That's the connection.
Yeah, it's how do you get stuff done?
Unit.
Yeah, interesting.
Exactly. So that's the sort of first element. And then as a result, you end up working quite a lot on building the infrastructure around the political leadership. So, for example, what does it look like to have a chief of staff or a team around a chief of staff that is specifically focused on delivery, which is actually not that common. Quite often you've got lots of political advice, naturally, quite a lot of advice on priorities, stakeholders, etc. Obviously, advice on delivery, as we discussed with the delivery unit, Prime Minister's delivery unit in the UK, that looks very different because it's much more about how do you stick with a priority? How do you know you've progressed against the priority? What have you measured? What might you need to do in order to unlock it or to re-emphasize that this is the priority so the rest of the system actually sticks with it? So from that perspective, it's partly about building the ecosystem or infrastructure, if you want, that allows decisions to be much more evidence-based, or the understanding of whether things are happening or not happening to be much more evidence-based than they can sometimes be. Because it's also true that, if you're at the very top of the political chain, you also have to rely on what people tell you. And so the less there are things being objectively measured and there's metrics, the the less you have to rely on what people tell you, how things are going. And there's always an incentive to make it look probably better than it is in any system. This is not specific around Sierra Leone. It's the same in the UK, right? And so building that sort of infrastructure. I think there is one moment where sort of your depiction of little evidence, the more senior you become, is true. And that is often about what do you pick as your political priority? What do you decide to focus on? In Sierra Leone, for example, in 2010, there was a strong commitment to providing free healthcare for pregnant women and young children, for example. Now, that decision, that was before I moved to Sierra Leone, but that sort of decision being taken. Now, of course, you could have said, what's the evidence for focusing on women in particular, or pregnant women, young children, compared to all the other things you could have focused on in the health system or sort of beyond the health system? And I think that is a 99% political decision. You just have to decide what is it that we're going to focus on. And I don't think that's any different in any other system, where the UK Prime Minister says, actually, these are the things that matter to us as a party, matter to me personally, matter to the public. And ultimately, the evidence is probably just as good for one as it is for the other, because they're all worth doing, and sort of making that decision.
I think that's a really interesting part of those decisions, actually, that at the highest level of policy, and we can talk about this from a healthcare perspective, Wes Streeting just coming in and Keir Starmer just coming in, Labour government coming in, that setting direction on healthcare policy is in part political and personal. I think that's really, really fascinating. And, you hear that the phrase, though, what is politics if it's not personal? That these are also ultimately humans making decisions, and those decisions from their experience and all these different things. But you're right, like nobody's actually telling them like what to set these big goals on. Like we hear the 40,000 appointments out of the Labour government. That's something that they've just absolutely decided, like it's a clear metric that they're going to head. To your point about targets before, that's one clear thing that they're going to go for. But it's funny to me because, yes, in part, those things have to be thought about in terms of votes in order to stay in power in one regard, and where you set the metric to make it achievable and measurable and all those things to give you the political power in order to stay in government. But then also there's a leadership component to that. You need to motivate an entire workforce. And it's really interesting, your position, actually. The sort of red thread throughout your career seems to have been you're someone in policy, but the parts of policy that focus on actually getting things done and actually implementing. And you might call it adoption, or that's probably like an analog within healthcare. This problem of adoption, people can say things and put things in place, but actually if it's not adopted properly, it's not going to actually work. That seems to be what you've tried to do there. But yeah, setting these political directions has to in part relate to, well, what's actually going to motivate, what's going to be motivational for everybody working in that, and of course the personal element as well. So it's just a comment, really. I just think that sort of stuff is fascinating as to how people set these things, and how votes actually, and the perception that I guess the people have on these things affects voting habits, and the voting habits is what people do in government. But is that the goal? Like, we're trying to make the country better. It's not just staying in power. And there's just all of these things that are in this soup of politics and power and policy.
And don't forget, James, there's there's a sort of moment of the election where it's very much about votes, and obviously that matters to some extent during a period of a parliament sort of for it. But that, going back to this idea of delivery all the way from prime minister or sort of ministers only happen if you really understand what the system and the complexities of the system is that delivers that. Let's say the NHS, and then healthcare providers, GPs, care staff, etc. And then in order to affect any of that, so much is about human relationships. Yes, some of it is about incentives, right? Tariffs, targets, performance management, improvement support. But a lot of it is about human relationships and motivation and taking people with you. And so I think a large part of politics is also about having conversations and setting signals to different audiences that helps you to take those audiences with you. Right. So you made the reference to the current government's commitment to 40,000 more appointments for it. I don't know. My personal view is that this is partly a signal to the service, but also to the public, that actually improvement and change can happen within the NHS. And that sort of narrative that it's only going to get worse isn't true, and it can be addressed. And if you can show, whether it's through 40,000 appointments, or you could take other examples for it, if you can show that actually this can be done, then that is part of a conversation, I think, to set a signal that change is possible, and change is possible within the current system. And then there's a separate conversation, I think, that happens specifically with staff, for example, around what either needs to be done or what can be done to address their challenges, whether it's in terms of burnout, vacancies, otherwise. But those two signals, or those two narratives, they're not necessarily the same, the one you have with the public, the one you have with staff. You might even have a further conversation, which is very different, or narrative and signals that you set, which is with the civil service and other departments, the Treasury, for example, what it means to invest in order to improve the system, or what you need to reform. And so I think sometimes when we look at messages that are coming from politicians, particularly in new government, it's quite easy to think, I'm not sure this message sort of resonates. But that might be because it's actually not a message that's sort of intended for you. Let's say for NHS staff, it might be a message that's intended for the public, or vice versa. And I think politicians all the time have to tread that balance between who they're talking to at what point, and taking them with you. So you're right about the importance for politicians to always think about where where their audiences are, but those audiences can be quite different, and they always have to take them with them. And only sometimes that's through votes. Oftentimes it might just be that you take them with them to be willing to do the changes, do the reforms, do the transformation, whatever it might be that they're later planning.
So sticking on this theme, actually, while we're on it, we've obviously just had a new government come in. We've seen a report commissioned, which for some of us on the inside and on the ground floor of healthcare might describe it as somewhat of a sort of let's state the obvious report of a report that comes along and says, what are the problems and where should we be focusing? Why would a new government come in and do that? What is going on behind the scenes as a result of that? What do you think and my assumption is that it's more of a delivery type tactic, that they're doing this to do something. It's not about the report. We know the answers. To your point about those politicians having multiple messages, multiple audiences, we've seen Wes Streeting meeting everyone under the sun in the last 4 weeks. He's literally he's gone everywhere and spoke to everyone, and I'm sure has done plenty of work as shadow minister as well. There's probably knows a lot of the answers. So what's the value of the report? What does that change or enable? And yeah, I guess from a health tech perspective, what might this mean?
Yeah. So I think the report, again, this is just my personal opinion, but I think this report is part of a narrative or a message to the public about what the challenges are, and to be able to build on that changes that the government might be planning through the longer term plan that they've announced they will publish. And I think that is because, it's not so much that the public or sort of patients are necessarily against change, but it can be quite hard to say we're going to change the way, for example, how you receive community and primary care or aspects of that.
It's happened so much, hasn't it? It's just happened so much, the restructures and the change to clinical pathways and.
For example, I just think that, the sort of unless you can really articulate to the public and to some extent to the NHS more widely and staff why you want to change and how the change is going to address the sort of particular challenge, if you can't do that, you've already lost them halfway before you're even having a conversation about what you're changing. Sort of if you don't have the why sort of to begin with. And so I think this report that they've commissioned on funding and performance is very much to establish an explicit baseline and rationale upon which to have a conversation around change. Because if people are not aware of that and you just move straight to change, right, then you might be missing out the rationale. And so for me, that's part of the communication to the public.
So it sort of adds a layer of defensibility, doesn't it? It's not a group of politicians coming out and saying, well, this is what we think is going to change it for the better and we're just going to do it.
Yeah.
They're sort of going behind this report that says, well, it's not us that thinks it, it's the report that thinks it. It's Lord Darcy who's run this report who thinks it. It's everyone that's in this report that thinks it, and here's what they said. And I guess that lays those foundations. Interesting. So with what you know of the inside of politics and I imagine changes of government, what do these first few weeks look like? There's a lot that's actually happened, seemingly. There are things that have actually been done. There's policy that's been changed. You've had the first whip recently, and things have changed. Like, it's actually happening, and maybe it's because I'm older and I've been in policy at arm's length bodies, and I've sort of seen this stuff relatively close. And I guess since then, and watching this election, and I feel a bit more connected to it, and I've been following it a bit more closely. But my reflection personally, based on what I've seen, is that things are actually happening at some pace. Things are actually changing. It might not be at the pace that everyone wants, and people may wildly disagree with that. But for me personally, and that's not to say I'm impressed with this particular government or anything. I've just, I guess, noticed it more that, hold on a moment, I am seeing a lot of change here. And it doesn't seem like mass panic of like, oh God, there's so much to do. And it seems like it's been a plan that's been in place. I'm just interested in what you've seen from the background of here. Like what actually happens in that transition of power, and what do those first few weeks look like? And from what you've seen in the UK, is it what you expected?
Yeah. So I think there's two aspects that are a bit unusual to the recent election and what happened after that. One is that you've had a party which for a long time was in opposition, and as a result actually had quite a long time with also the same people over a reasonable number of years in shadow government, being able to think about and to some extent prepare what the priorities and approach was that they were going to take if they come to power. I think it's the sort of first element. And then the second element is that there's been a reasonably long period of several months where, while it wasn't a foregone conclusion, there was a very strong expectation of the result of the election and how it would pan out through polls, sort of, etc., which adds another layer, I think, on the opposition to really prepare about what are we going to do when we then actually get into power. And that's not necessarily usual. Sometimes it can be much more of a surprise for the party who goes into power. Sometimes it can be individuals who've only been in that shadow minister role for a very short amount of time, and then suddenly they come into power and have to figure out what to do. Sometimes they're so focused on the elections and campaigning that they actually haven't been able to really focus on what to do sort of on the first day. So I think that's a little bit unusual after such a long time of one government sort of moving to a new one with that sort of expectation of it happening, which added to that ability to prepare and focus and learn from what happened back in 1997, because a lot of those politicians, of course, are still around and are now part of the conversation, for example, in healthcare, as we know. So that's sort of one thing. The sort of second thing I think that goes on during those sort of first few weeks, there is a lot of, what do you want to call it? Going back to maybe I think this is what ideally goes on necessarily rather than what goes on. But there it doesn't matter how much you've sort of signaled and communicated before the election. This is what we're going to do when we get in. Here's what our manifesto says. Here's everything we said around it, for example, healthcare. That doesn't mean everyone, once you are in power, either agrees with it or quite believed it when you said it the first time before the election, or understands how to do it, when it sort of happens. Because it might be very different, very new, very challenging, more ambitious, whatever it might be.
Well, to your point about the requirement of delivery units.
Yeah. And so I think during the first few weeks, a lot of time is spent on both building coalitions and relationships from ministers with the department, with the service, with the medical associations, Royal Colleges, for example, for it, but also to communicate, this is what we said and this is what we're now going to do. and we are going to do it. So that sort of, I think there is a sort of iteration loop going on during the first few weeks of government, that this is now going to happen, and this is how we'd like to do it, and we want to build that relationship to make it happen. And I think it's incredibly important, because then once the starting pistol is fired to make that change happen, if you haven't had those conversations, you might suddenly run into resistance, either directly or indirectly, sort of through inertia from the service. So I hope that's what's going on. But I expect that is why you see a lot of meetings, a lot of appointments, a lot of communication, so a lot of things being talked about, because it's all part and parcel of setting up the delivery and making it happen with all partners involved.
So the new government has also announced that they've got a lot of missions. Is this a similar way of talking targets as per the last government or last Labour government? Or do you think this is a different thing entirely?
Well, we don't quite know yet what the missions are exactly, right, and what they're going to look like. But I think there's a similarity, and then there's a big difference. I think the similarity is to try and really articulate for a number of years, what is it that we want to achieve as a government, and we're going to pay attention to this over a period of time. And that's similar to setting targets from that perspective. And I think it's important, because delivery takes time. It's a long slog and grind often to make things happen. So if politics just moves on, you lose the attention, you lose the focus, and things may not sort of happen as a result. I think the really big difference is that the missions, the way they've been talked about so far and before the elections, is that they're much more cross-government, certainly cross-department focused. So it sounds like the mission in health is going to focus much more on health rather than healthcare, which means there's elements of prevention, wider determinants of health, which I think is very important and powerful.
Yeah.
If we want to address healthy life expectancies and inequalities within that. But that's very different from a specific service delivery target that you can address, because it adds another layer of complexity.
Yes.
Into it, and probably the way you can achieve the missions isn't about just doing one thing and doing it really well and doing it over and over again, but it's to do several things, and then those several things sort of being put together all contribute to achieving, for example, healthy life expectancy in the UK. So it's quite different, and I don't think you can just sort of translate from the delivery unit model to a mission model. It has aspects of it, but I think it's quite
interesting.
Different.
Yeah. So they're more zoomed out, they're broader. But actually, it sounds like, well, if you did want to improve things at a broader scale, you would choose mission over target, because there's nothing to suggest that a literal target results in better health overall. If you're going to zoom out entirely, there's a lot of assumptions between there and the eventual things that benefit us as normal people living normal lives, I guess.
Yeah, or maybe also, if what you were trying to achieve is just improving a particular performance or process within the current system in the NHS, right? If it was just around waiting times, now we want to improve waiting times, of course, but if it was just around waiting times, then you possibly, big debate around this, right? Because possibly trying to attack this sort of as a target and how you see the numbers change. I think what we've got ahead of us, though, is not just optimizing, improving the system as it is, but trying to actually change how the system overall runs, right? How care is being delivered, where it's being delivered, by whom. This is where the role sort of technology comes in. And so once you move from trying to just improve the system within its sort of own parameters towards shifting those parameters, I think that traditional delivery unit approach of setting a particular target within the system is not going to get you there, because you actually have to say, what's the outcome? Healthy life expectancy, for example. And in order to achieve that outcomes, how do we shift the parameters and the setup? Not the structures necessarily, because they've said they don't want to change structures in the NHS, but how do you change the parameters around that? And I think that's what makes the biggest difference. And we know that we have to do that, because we know that the illness, mobility challenge that's coming down the track is going to be so significant. And this is my view. I mean, at the Health Foundation, we've done some projections that show by 2040, so not that far away, 1 in 5 people will be living with a severe illness, i.e. an illness that needs some form of healthcare support. That's 9 million people or so. That's a very, very large number. So the best possible productivity improvement we can do within the current system is not going to help us with that. It might just sort of stumble along a little bit better, and then we've got the same challenge. And so I think that is partly why the approach towards the mission has come in rather than focusing on targets.
Do you know what? That is such a helpful explanation to understand what actually might be going on here, because when you put what you've just said next to the fact that they've just commissioned this report on funding and performance, and you consider the role that tech and, particularly AI that everyone's talking about at the moment can play in redefining how a system works in its entirety, this all starts to converge and make sense that what might be happening here is that we're laying the foundations, or this government is laying down the foundations for a truer system change. Because as you say, trying to fix the system from within the current system will only be as good as whatever we were hoping when that system was put into place. And, fire can't burn itself, a knife can't cut itself, etc. We can only be as good as the constraints in which we're put. We're never going to ascend beyond them unless we change that entire system. So I think that's really interesting. And I think that leads me nicely into the next part of this, which is the Health Foundation. And you guys have done your strategy for AI in the NHS, and the event that you recently had. So you've been talking about tech, and you've been talking about system change, and you've had, some big hitters there explaining some really interesting things. You've written other reports that we can talk about. But before we go into those, talk to me about the Health Foundation. Talk to me about where the Health Foundation sits in our broader health tech or even healthcare ecosystem.
Yeah. So the Health Foundation is a charitable foundation. Now we've got an endowment from which we take our funding and our work. And our mission is to improve health and healthcare in the UK. So we work across all the nations, and not just on the NHS, but also wider health and health care. And we've got three broad strands of work that we do. The first is to try and support and improve health and the role of wider determinants of health rather than healthcare. So all the way from poverty to education to housing to nutrition, and how that can be affected for health and more equal health in the country. The second one is to help improve both policy, but also the analysis that informs policy, whether it's wider NHS reforms, social care reforms, comparisons internationally of how the UK is doing that most think tank aspect of understanding policy. And then the third one, which is the portfolio that I oversee, is about supporting what we call radical innovation and improvement in the NHS, i.e. to try and help understand what can be done, but very importantly, how it can be done. There's lots of ideas of what can be done and how you change care, whether you improve it, within the current system or transform it into a new system. But actually, I think where the unique contribution lies that we as the Health Foundation can bring is that we can spend a lot of time on understanding the how. Well, how do you do adoption and spread? How do you do implementation? How do you do evaluation? And learn from that how. So that's broadly what we do as the Health Foundation. We partly do that through analysis and research, and we partly do that through funding that we can can deploy. Now, I guess a couple of things around it. The first one is it always sounds great to be able to say we're a foundation, we can deploy some funding. Compared to the £160 billion industry that is the NHS, just in England, the amount of money that we have available to spend is tiny. Right? So someone did some calculations at some point that suggested something like, our entire funding for a year would keep the NHS going for just a couple of hours, something like that. So there's first of all a very important aspect of humility in this, but also it means to really think about, if we spend our money anywhere, what can we help unlock that's actually different and can lead to something else? So we get the most out of the amount of money that we can spend, because just adding it on top of 160 billion is not going to help anyone.
Of course.
Right? So what are the small things that we can do and make a difference? And that means two things for me in in any case. One is to, wherever we provide funding, for example, on helping to demonstrate how you can adopt and spread an innovation for that. We're interested in the funding partly having impact because something positive happens, an innovation has been spread, for example. But we're just as interested in learning and understanding how that has happened and what the method, the approach is, because that is the bit we can use to then try and inform and influence policy. Because if we can influence policy, then our funding hasn't just achieved something very local and specific on the ground, but it might also actually lead to something more that, that sort of unlocks a wider decision. So it's that sort of funding for impact, but also funding for insight and funding for being able to shape policy. And I think that, it's for others to judge, not for me, but I think what makes the Health Foundation a little bit different is that we have the ability to deploy funding and work really closely with practitioners, whether it's in the NHS or, and obviously in health, it's a much wider range of stakeholders, to understand how change happens on the ground and then use that to inform policy.
Is there an example that comes to mind when you think about that? You think about that going well. Is there an example in recent times where you've picked something, you've done that, you've done a funding exercise, you've learned something, or something's worked, policy has been affected, things have changed? Is there an example that comes to mind?
I mean, often it's quite a long chain, and not necessarily how you expect it for it, for example. So one example is that a few years ago, we launched a funding program called Adopting Innovation, which was supporting 4 innovation hubs, they were called, across England. And initially, they were all placed with trusts. And the idea was that we could provide them some funding, and their role would be to take a particular change or innovation and adopt it and spread it in a sort of local area. Now, the extent to which each of those hubs has spread something specific is a bit mixed. But actually, what we learned about most from that particular example is what you need to do in quite a local place to understand what the need is or the sort of problem you're trying to solve, what the change might be, and then how you build the coalition and buy-in of the public, of the staff, the wider system to make that change happen. And actually, it's that learning about the how that has been most powerful for us, and it's then what has been feeding partly into some of our reports. It's been feeding into aspects of what we said, even in the report on calling for an AI strategy around adopting and implementation, so taking people with us. So what we set out to do with that funding a few years ago isn't necessarily what we got out of it at the end. But what we learned over that period of time, and by the way, this was a period of time where lots of things changed, right? ICSs were established, the health innovation networks, sort of grew and took on their role in adoption and spread. So actually being part of that evolution and sort of development meant we've learned huge amounts about the how, even as what we've achieved on the what is not necessarily what we thought at the beginning. And that's a bit of a luxury to have as a foundation, that we can spend money on things, and even if they don't quite work out from an impact perspective at the end, if we learn lots of things around the how and can then take that into our reports and our policy influencing, or so trying to shape support, then that for us is still incredibly powerful, and indeed can be maybe where we make a bigger difference, because we can unlock a more national policy decision, which will affect a lot more things than just the local.
Yeah, right. So what is an example of a policy that you would be lobbying for or against, or so in that example, right, of you're trying to spread adoptions locally in 4 different geographies or regions, you've learnt either specific things in each local area, and you may have learnt that actually a lot of the problems are very local and they change per geography. You might have learnt that there are some issues that are felt across all that would justify national policy change. What sort of policy change, as I say, would you be lobbying for as an example out of a project like that?
Yeah. So the really big one for me is what we term in the slogan, fund the change, not the tech. This idea that unless you are willing to invest in the change skills, the change capacity, the time to engage with people, the time for NHS staff or care staff to be able to engage with it. So unless you invest in that, either through money or through time or sort of resource or capacity and expertise, the best technology is not going to make any difference. Now, that doesn't sound like rocket science once you've said it, right? It sounds pretty obvious. But the reality is that the thing that's often sort of politically exciting is the announcement of the new thing, right? New kit, new this, new that. And making an announcement about, we're funding 10 people in this locality who are all change experts, and they're going to do process analysis to really understand how this new remote technology is going to change ways of working. Well, that doesn't sound very exciting, does it? But actually, unless you also focus on that, let's say the remote technology monitoring technology by itself is not going to do anything. So that's something we've learned over the years as a foundation, and it's something I've been calling for some time. And what that sort of means for policy, I think, is very specifically like, where does this capacity of an understanding for change come from? Because it's often the first thing to go, when there has to be funding savings found. And so, you're not going to take clinical roles out. You might take sort of change roles out. But it can also mean that you get quite unequal approaches in local areas, because if you have an ICS or sort of a local footprint with, let's say, 3 really big trusts, university trusts, with universities, etc., they're likely to have some capacity, resource, expertise in change that, in an ideal scenario, they can deploy across, the system to support some of that. Now, I think people in those areas would say that sounds nice, but we don't have it either because the system is so stretched, right? But they will, relatively speaking, have way more capacity and opportunity than a region that maybe has 1 hospital and otherwise is really just, maybe 1 community provider and primary care, and otherwise is, let's say, very rural rather than urban. And so the other thing that can happen is that you get these areas that can just about make it because they have the luck of the circumstance and how they're set up, and other areas will become ever further behind. So unless you're willing to invest in the change, and invest in the change in a way that it's meaningful in whatever area you're in, you're not going to see that. You're not going to see that transformation. And if we're talking about a transformation of the NHS and a transformation of care pathways, I think that funding for the change, that investment in the engagement and the capacity and that expertise needs to come from somewhere, not just the investment, let's say, in the technology or the idea. It doesn't have to be super expensive, by the way. Yes, of course, some things are very expensive, particularly some of the IT can be very expensive if it's the fundamentals sort of for it. What we're talking about here can be about allowing clinicians or nurses to actually engage because someone backfills the role for that period of time. It might be change expertise or change capacity for people you bring in, or roles that you create around that. So we're not talking billions of pounds, I think, to create and sort of support that change. But unless there's something dedicated to it, it's not going to happen. A neat example, this is a few years old now, but in 2021, we did a mapping of all the innovation funding programs in the NHS at the time. And I think it was about 31 at that point. And of those 31, only 4 were funding programs explicitly for adopters of innovation. Everything else was for innovation, and some of them for also adoption. And it's that we sort of tend to go to, what's the new idea? And then, we also have to adopt this thing and deliver it. But that's all a bit, sort of technical and boring. We sort of forget about that. But actually, we have to put just as much focus into it. And that's partly what I see as my job. I want to make implementation exciting again. Not entirely sure always how to do it, but that's what we're trying to sort of support and launch.
It's so funny. One thing I've seen play out over the last, it's not, in fact, it's not funny at all. One thing I've seen play out over the last 10 years that I've been doing this sort of stuff is the lack of attention on that adoption piece, and what results is a lack of confidence in new innovations, full stop. Because the failed project, in inverted commas, of bringing that new technology in is sort of just associated with, you try and bring new technology in and this is what happens. we don't get educated, we don't get trained, we don't get educated on it. Like, we haven't got the time to learn it. Now all my processes that have been standing up on, you know, the workarounds that I've been doing, because I know the reasons that this tech doesn't work. So I've set all these workarounds up, and now I've got it working really fit. Like, it's the lack of confidence that then comes with change, full stop. And that's a really tough one, because I can remember the sort of excitement around digital health. You know, you're looking about 10 years ago and this sort of stuff was coming out, very healthy skepticism to it, in some initial projects being done. But then subsequently, when we didn't know so much about how important that adoption bit was, those initial projects not doing so well. And then just real clinicians, my friends, people I know, like on the ground floor, just having this stuff come in, and they just lose confidence in not only that piece of tech, not only that project, not only that thing going into that department, but actually just in change more broadly. And I think that's really tough. My wife is pregnant at the moment, and we went for a scan, and quite just a really obvious example of this. The lady doing the ultrasound literally just said, "Oh, sorry, things are going to take me twice as long today because I've just had this new computer system. I haven't got a clue how to use it, and I don't know how to do blah blah blah. So just bear with me." And it was just like Jessica and I, both in Healthtech, both co-founders of SomX, we both looked at each other, just being like, this is just an absolute front row seat to this whole thing, this whole piece about, as you quite rightly say, fund the change, not the tech.
And I think even big initiatives like, let's say, electronic health records, their implementation, they're huge IT transformation programs. I've got no claim whatsoever to be an expert in that, or being able to sort of do that. So I've got huge respect for those transformation programs. But they're not just big IT transformation programs. They're also people and workforce change programs.
Correct.
And I think what has tended to happen is that a lot of focus has been on implementing the IT, getting into place, yes, providing some training, doing the integrations, etc., getting it running smoothly, safe, secure, which is important and great. But then there's a whole other piece, which is about, okay, how do you now engage the workforce so they actually change their ways of working on the basis of what can be done? And if you go around hospitals and look at how much have electronic health records also started to really change ways of working on a ward, on a pathway, how is that information data being used, you get very, very different answers. And I think that it's because we haven't yet put change expertise, improvement expertise, real understanding of workflows and processes onto this, and said, let's say to a ward, we now have this data available through the electronic health record. How do you do things at the moment? How could things being done differently because you have this information? And what as a result do we want to change? Now, that's a very different skill from implementing an IT system. That's a workforce and a workflow sort of change program. And I think there's so much opportunity and potential to do that. But it requires dedicated support and capacity, that sort of change that we haven't yet put to it. And I sometimes think that, we had Bob Wachter's report back in 2016, was it, where he made the argument for all hospitals having electronic health records, having chief clinical information officers, that sort of sense of we need to digitize. And the NHS has made huge strides since then, and to some extent it has digitized. I know there's still pockets where that is sort of underway, but broadly we have digitized. Now the next step is, okay, on the basis of digitization, how do we change the way we work and optimize it? Whether that's in terms of productivity, whether it's in terms of making it easier for staff, patient experience, sort of otherwise. And I sometimes feel like we need a whole new report and priorities from that argues actually, in order to now get the most out of these systems that we spend tons of money on, what do we need to do and over what period of time? Because it probably is another 5-year period to do that. And I don't think it's unique. If you look at the US, of course, they're ahead of us in terms of having electronic health records, but they also spend years, I think, realizing how those health records affected ways of working, and not necessarily in good ways, for their clinicians, and are beginning now to optimize and improve on top of them. So they're a few years ahead of that. But I think they struggled with exactly the same challenge, and we can learn a lot from that, and maybe jump one or two of them. I mean, bring that back to influencing policy, delivery, sort of new new government, I personally think around technology, I personally think that it would be quite important for the NHS, sort of for the government, to actually articulate 2 or 3 priorities and say, over the next 2 or 3 years, we're going to demonstrate how this technology is genuinely going to change and make a difference. And that's for sort of 2 or 3 reasons. One is, as you say, there's quite a lot of cynicism that it can be done or how it can be done. And I think unless you generate some hope, if that's not too grand a word, to show people that technology can actually make a positive difference to them, you're not going to overcome that sort of resistance, inertia, or worst case, sort of cynicism for it. But that's not just for staff. I think it's also for the public, right? The public has not been won over yet. That technology is really the thing that's going to help them. We've done polling. We regularly do polling. And on balance, people are supportive of technology. They're supportive of using their data for research. They're supportive of AI. But it's always on balance. And there's usually about a third who say, not so sure, might make it worse. And that's a pretty big chunk of people you sort of still have to take with you for it. So there's something about demonstrating to show that can be done and sort of show the hope. But there's also about demonstrating it to focus on sort of how it can be done and not pretending that'll happen by itself. Right, and to actually invest and support that, invest in the change, so make it happen. So we say in the report we've done on having an AI strategy for the NHS, we actually say that ideally there would be 2 or 3 priorities, where particularly around a technology like AI, but I think it holds generally for technology, but so particularly for AI, being able to show that it works is incredibly important. And personally, I would pick one priority that's explicitly about making life easier for staff. Freeing up time to care. Nothing else would probably be non-clinical, operational, admin focused. I would probably pick one that's very much about process efficiency and current challenges, maybe waiting times, selective triaging, sort of otherwise. And I would pick one that's explicitly about pathway transformation to show that technology isn't just about, changing one cog in the whole process, but can generally transform the way in which you receive your care, or when you see a doctor, or how you're being supported. So otherwise, I know that's much easier said than done if you're in a department or sort of an NHS, but that sort of prioritization over several periods of years, putting support behind it to show that it can be done, I think is incredibly important right now. And for new technologies like AI, where there's so much uncertainty, misunderstanding, lack of clarity still in it.
You guys recently did the event on your strategy for AI in the NHS, which you just mentioned. What else comes to mind that sticks out from that event? I've seen a lot of people talking about it on LinkedIn. I know Hugh from our team went as well and has written something up. But what sticks out for you? You've mentioned one thing about, the priorities and 3 things there that optically would demonstrate from the micro to the macro things can change. I think that's a really interesting thing to do. And a very interesting recommendation. Anything else that comes to mind for you?
I mean, one thing that sticks out to me, because it was such a great phrase. One of the reasons we give for saying that there should be a dedicated strategy for AI, and of course there's a debate to be had. Do you need a dedicated strategy, or could you, sort of weave it through everything that the sort of NHS does? We think there should be a dedicated strategy, but one of the reasons we give for that is that if there isn't a sort of coherent focus on all aspects of the NHS being able to go with this new technology and opportunities, you will create pockets who can do it because they're big hospitals. They have the data access, availability, data sets, whatever it might be, capability, clinicians, analysts, etc. And one of the questions that came in around that during the event, which it turns out was actually crafted by one of our interns, Elliot, at the Health Foundation, was great. Which is like, how can you avoid an AI aristocracy in the NHS? And so it really stuck with me. It's a great phrase. It's this sort of sense that, well, if those who can afford to do it can advance within the NHS, but the rest is left behind because they don't have the data sets or the staff or the challenges day to day that they're sort of facing, we haven't really made the most of this as an opportunity. And to do that, you need a dedicated wraparound understanding of, okay, how do you support those different places? I think it's the same sort of challenge around AI aristocracy if you look at it not from the perspective of services on the NHS, but from the perspective of patients and the public. If you're if you've got the means and the money and the technical know-how and the connectivity as a patient, over the next few years, you can probably get huge amounts of technology. If you don't have that, and we know that there is a big difference in terms of sociodemographic, in terms of access and trust and ability to use technology, etc. If you don't have that, we may end up with a system where some people benefit hugely because they can and others don't. And again, unless you think about that from the outset and ask, how can everyone benefit and how can this be, sort of a force for greater good for everyone, then you're really missing something. And so that was a really big other part that stuck with me from the event. Oh, and that the minister said she agreed with the report and they would turn it into practice. That obviously great.
Fantastic.
To hear. Yeah,
oh,
obviously it looks different in reality when it happens, but that was nice to hear.
Yeah. No, of course. You mentioned freeing up time to care as a phrase, and I know that's something that you guys have taken a hard look at. Obviously, it's the promise of technology, isn't it? The promise of technology is emancipating us from administrative burden, freeing us up to practice at the top of our license, freeing us up to do the things that only humans can. So many conversations I've had recently about AI and LLMs and the things that they can do, and moving us from the logical to an emotional in terms of our value and the things that we can add, and empathy and all these different things. From the work that you guys have done, what does freeing up time to care mean for the individuals and for the system?
Mm-hmm. I mean, this sort of came out of a question that popped up in the team at some point, which was, what's the evidence actually? What do we know about what technology frees up time to care, and how because we all sort of
what a great starting point, right?
Yeah.
So let's challenge that assumption first.
Question popped up and someone said, maybe we should look at this. And so the first step then on this work was to do a rapid literature review. So it's not a full singing and dancing academic literature review, it's sort of rapid literature review to look at in the literature what does the evidence show about sort of freeing up time to care. And now it showed that there's quite a lot of evidence where technologies have been looked at, and it has been shown that it has freed up time to care in one way or another, which is great and positive. But it also showed that less than 1% of those reports that the rapid review looked at, less than 1% then also showed and had evidence for what people did with that time.
Interesting.
And so, of course, it's great if someone says, I can free you up time, but then you don't know what happens with that time. And what if that time goes into, I don't know, let's say you've got a great technology that helps you improve how the prescriptions are being done. If the pharmacist then needs to actually spend additional time and double checking all the prescriptions after they've gone out, you haven't actually freed up any time. So you really need to understand where the sort of time is being used for it. So we found that most evidence doesn't talk about what people use this time for. And then we said, okay, why don't we ask people? And so we did this survey across 8 Royal Colleges and professional bodies of different professions. And we particularly picked those where there's quite a lot of strain and stress on the system and on the workforce, and asked them both, what technology do you think would help you most to free up time? And what would you do with that time? And on the sort of technology, that the most insightful aspect for me on that was that people primarily said what would help me free up time is technology around communication and collaboration and electronic health records, i.e. the sort of digitization of data. And then we asked the same question, and what it's like in 5 years' time. And it was, again, both of those things. And then also, AI helping with things like imaging or administrative tasks, etc. But what I sort of take from that is where we actually should be putting a lot more effort is those sort of non-clinical tasks, and how can those be made easier, and the tasks that enable people to in their everyday ways of working, and how staff work together, because that's much more likely to make a difference than the latest medical kits or therapeutics, as important as that is at the same time. So that was the sort of first one. When we then asked people, what would you do with your time freed up, and we asked, what would you do with half an hour, an hour, 2 hours, 3 hours for that. The good news is that most people said they would use it for more care activity, so we'd sort of like to see it. The sort of bad news is that once you average that out across the different timings, etc., and what everything else said, it's only about a third of the time that people would use to do more care. And a lot else goes into training for more junior staff, improvement, research, reducing unpaid overtime, so all the sort of things that we'd expect people to do. Now, you can be sort of cynical about that result and say, okay, actually, whatever 100% of time a technology frees up, you should always assume that 70% of that time is just going to go in the ether somehow. And it's not going to help you with productivity. That's, of course, not true, right? If people invest in training or research or improvement, or indeed just having a longer break, that indirectly may make them a much better at their job, safer, higher quality care, spending more time with patients, etc. I don't think that's sort of necessarily the right way of looking at that result, though. I think it's much more about, okay, people value lots of different things in the time that they can spend, it's been made available to them. And if we implement a technology and we don't at the beginning have a really good conversation with staff and with patients about what do we value in our time, then whether this is a success at the end or not might fall flat. Because if you haven't agreed that, yes, you should be using your time to reduce unpaid overtime, for example, or yes, you should be using your time to have a longer break, or yes, you should be using your time to ask the patient how they're doing, in an extra 2 or 3 minutes in your consultation, even though it doesn't sort of necessarily add anything directly to that question. And then it might be actually super successful for 30% of time to be spent on more care activity and 20% on, more patient direction, 20% on improvement. But so that conversation with staff and that real understanding from the outset, what do we value in time freed up, and what does success look like at the end of it, and how people use that time? For me, that's at the sort of nub of what good implementation looks like and what we can learn from that work.
That's super interesting, and I think it's funny because as you're explaining that, as an ex-clinician myself, and ground floor healthcare worker, staff in hospital, representing all those groups here, like, it's funny because part of me gets really defensive and thinks that you're questioning my integrity in part there, which I know is a very emotive reaction, to be like, just give me the time. I'm in my scrubs on an intensive care unit. Trust me, I will find very valuable things to do. Or indeed, like the break, as you say. I think the definition of it, though, I think is important, because it flipped as soon as you said unpaid overtime. I think that's really interesting, because I think that as a phrase just represents, if you can extend that definition into everything taking longer and bleeding into the next task, you can sort of even extend that definition to, like, what if I'm an F1 on the wards and I've got 6 bleeps of things that seem urgent and important that then build up? Like, I'm going to class that as just like unpaid over. Like, I'm having to now do my task incredibly quickly. That there's risk associated with that. There's the fact that if I had more time and my senior had more time, we would perhaps triage those 6 things together. I would receive education and training. My cognitive load would decrease. I'd perhaps be able to split that time amongst other people. Like, there's a lot in there, but I think that's it's a really important piece of work to do, because and to actually seriously explore, because I think there's plenty of things that you can find there with, like, stress and cognitive load, and like, and that's just talking about 6 bleeps building up. I can remember as an F1 doing ward cover in the evenings, and just how ludicrously stressful that is, because you've just got so much to do that you're having to figure out what's urgent, what's important. Do I see the person with abdo pain? Do I see the person who needs their warfarin dosing? Do I see the person who's got leg pain or a headache? Do I see the nurse who needs the drug chart, like, rewriting? Like, all of these things need doing, and they need doing at some point on my shift. And what doesn't get done will get handed over. But I think whatever piece of work that's done to figure this stuff out, like, had I had more time, all of that stuff would have got done. It wouldn't need handed over, but also my cognitive load would have decreased massively, and lots of other different things and bits and bobs. And, I wouldn't have, and in the extreme, it turns out the person with abdo pain actually had chest pain, actually was having an MI, and I got to last because I deprioritized it, because actually they were in for something that they were post-surgical a few days, it wasn't that bad, and the nurse gave them paracetamol and they were broadly fine. So I actually deprioritized it and put it last. Had I have had more time, they would have got severe. So this and actually would have cost the hospital a lot less in There's so much in there. And if you talk to someone like Keith Grimes, they will just say, don't worry about it. Just give us more time and we'll solve a lot of problems that are nondescript. Like, do not worry about what we're going to spend the time on. Like, we're just going to do it. But I can understand that finding a way to quantify that actually empowers staff so much, because actually, once you lift that rock and you have a look at what's underneath it and the mess of what's underneath it, I actually do believe that there are so many answers there. And I think it's fascinating that there is an organization like yours that actually has the ability to do stuff like this. I think that's so powerful in healthcare. I think it's so important. And the link between doing that piece of work and then your ability to actually affect change through policy. You know, people can talk about policy as being slow. People can talk about and I've said these things. I've worked in policy and all the rest of it. But I also know that you can lobby for a policy change and something can literally change overnight. You can put a piece of policy in that says that GP practices have to have 24/7 triage cover. Now, all of a sudden, you have now laid the ground for AI triage to now proliferate across the country, because nobody wants to staff a phone 24 hours. You've now just said that, you've just literally just passed a piece of policy that says 24/7 triage is a requirement. All of a sudden now you've enabled an entire marketplace of tech solutions. And people don't realize I don't think there's a lot of people that don't realize how powerful policy can be in an example like that. And it's fascinating to me that, as I say, you guys can do a piece of work like freeing up time to care. Like, what would that time be spent on? Well, actually, let's start at the beginning. Like, what should that time be spent on? Like, what are the problems? And no one's actually thought to go back that far. But my goodness, I think there is so much good that could come from quantifying all of that stuff. It would just be a thread that you'd have to keep on pulling for quite a long time, I think. And I wonder what on earth would be the end of it.
I mean, what we now want to do is a good example of, I think, what we can do at the foundation. Having sort of made that argument, we're looking to fund a piece of work to actually demonstrate how you can really well measure time, not whether it's been freed up, whether it's been freed up, but then also how people use it. So we've got a demonstration of the how, not just the what that particular piece of work in a particular location size, to be able to say, look, if you really want to understand whether this technology has a benefit, this is how you need to think about monitoring impact, or this is how you need to think about evaluation to do it well, so that we can also give that to the practitioners and say, so if you implement this, here's a way that you can look at sort of have a go at it from that perspective from the outside.
Awesome. Malte, listen, it's been an absolute pleasure. I feel like I've learned so much here. I feel like I've learned a lot about what might be going on behind the scenes of government at the moment. I feel like I really understand what you guys are up to at the Health Foundation, where you guys fit in. And I must say, it's an organization, a foundation that I think does such important work, and so important that you don't receive your funding from anyone that we could turn around and say, well, they've done it for X reason. I think you having the independent nature and pure intentions and a will and a desire to actually make things work, and based on your background as well, always being part of units that are focused on delivery, actually getting things done, you represent that side of policy that wants to genuinely affect change and will find a way. I think it's super important what you said about the what being important, what can be done, but the how also being incredibly important, and learning that if we learn the how, if we do these projects that have varying levels of success, if we can also appreciate the how and then distribute that information, then distribute that learning, that is what is going to move us forwards. And that's what I've taken from this as well, that I think it is incumbent on potentially even the startups that, I mean, we do this as a startup community and a tech community quite a lot. We meet, we discuss, we complain about things, and we talk about how things worked and why they didn't. I actually think that's possibly more important than I've perhaps thought of before, because I think in those conversations, which are largely had for solidarity, I think there's actually a lot of shared learning that can occur there that might be incredibly important for how we go forward. I hope that what we have now is a government that does want to affect change, that is going to do this report, that is going to figure out or at least put markers in the sand of, hey, this is what the report's shown, this is what Lord Darcy has shown through the report. We're now going to put a load of things in place to what you talked about from the very top to the very bottom around delivery. And here's practically how we are going to go about things. Early signs look positive. And I think, honestly, it's been an absolute pleasure having you on and hearing all about it. So I really appreciate it. If people want to hear more from the Health Foundation, I should say, Health Foundry being something completely different. Yeah. If people want to learn more about the Health Foundation, what is the best place for them to go?
The website, obviously, lots of reports and work on there. My email address is also on the website. So if anyone wants to get in touch, you made the point, James, about learning about the how. We often try to convene people to learn about the how, doing that also with health tech, with startups to support that. We're not going to be able to support sort of the health tech world with lots and lots of funding, nor does the world need another VC sort of for us to. We
actually do at the minute, but that's a different story. But yes. one that's actually got money to deploy right now would be quite fantastic. But we won't get into that.
But I hope we can do a lot by learning about the how and then feeding that into the policy work that we're doing and trying to sort of support that in the national policy making, but also learning about the how, particularly around the evaluation and how you generate the evidence for that. So if anyone wants to be in touch, have a word, share their experience, I'm always super keen to learn and hear about that as well.